So with that, I think it's a decent segue to Ash, who's here and is going to talk to us about the heart failure doctor's perspective on taking care of patients with mitral regurgitation.
Good morning, everyone. I'm Ashrith Guha. I'm one of the heart failure transplant cardiologists with the heart transplant program here. So I'll be talking about mainly, heart failure with reduced ejection fraction along with MR and how we approach it, at least from a heart failure perspective. So these are my disclosures. I'm a heart failure cardiologist, so you're not going to see any pretty pictures that Colin just showed you. So through the talk, we'll be going over stages of heart failure, identifying Class D heart failure, and recognizing what is optimal medical therapy, and especially with regard to target dose, and recognizing polypharmacy in heart failure patients as a barrier to achieving target dose, and the role of CRT device therapy. Again, all of this is really geared towards patients who have HFrEF and with concomitant mitral regurgitation. So to begin with, this is the natural history of patients who develop, HFrEF. So patients start off here having heart failure, and immediately after they develop heart failure, within the first year, that's when their risk of sudden cardiac death is, highest, and that's what is aborted with an ICD. And as you, go through with natural progression of disease, an average, at least in natural history studies, mainly from the 90s, it takes almost about 14 to 16 years before they progress to needing anything more like heart transplant or mechanical circulatory device. And that's when they present with pump failure. So this is the newer paradigm of stages of heart failure. And as you can see here, we are really, looking at stage C. Stage D, stage A is where patients really don't have disease but have risk factors. And stage C is where they manifest with heart failure. And as I just want to draw your attention to this bottom part here, where this is where, if revascularization or a valvular intervention is considered appropriate before they, enter stage D heart failure. So as a heart failure specialist looking at patients who have, a valvular regurgitation, I think I see my role predominantly as twofold. One is to identify patients with stage D heart failure who really will not benefit from any valvular intervention. And secondly, to identify patients who have stage C heart failure who have not been optimized, and with optimization may not need a valvular intervention, especially the functional MR kind. So with these stages of heart failure, do they really give prognostic information? And this is a study from Mayo Clinic, which does show that when you have stage D heart failure, your prognosis is really poor, and you're really dealing with a myocardial disease here, and end-stage myocardial disease. And stage C heart failure really can be divided into stage C1 and C2, and this really is based on their symptoms and number of heart failure admissions they've had, and we'll go over that in a little bit soon. So this is the Intermax classification, which really started after the mechanical circulatory support devices came into use. So I'll just spend a few minutes on the slide, and these are all patients with advanced heart failure. So all of these patients have NYHA class 3 symptoms or more, but yet they can be subdivided into multiple classes. And when you look at Intermax class 1, 2, these are patients in the hospital on balloon pump or temporary mechanical circulatory support or multiple inotropes who need an intervention in the next few hours to days. And these are patients who have multi-organ failure, and they need a durable intervention in the next few days. Going up, patients with class 3, Intermax class 3, these are patients who are at home but stable on an inotrope. And these are deemed inotrope dependent. So when we say inotrope dependent, that means there has been at least 2 attempts made to wean the inotrope, and that has failed. And failure is defined as either symptomatic hypotension or worsening end organ dysfunction when you take patients off of inotrope. Now, these patients, Intermax class 4 through 7, these are patients who are at home, but from 7 through 4, progressively not doing well. Patients with 7 are those who have had an admission in the last 12 months, but are stable on medical therapy. Now, 6 are patients who are requiring IV diuretics, either in the ER or in your clinic, but are stable at home. Now, class, Intermax class 4 and 5, these are patients who have either ambulatory class 4 or class 3B symptoms, which means they are not able to do their IADLs. They are not able to take a shower. They're not able to do anything without getting short of breath at home. And when we look at class, defining stage D, you're really looking at patients from 3 to 1, or sometimes maybe 4 through 1. So these are the ESC criteria for advanced heart failure. Very similar, again, repeated hospitalizations, progressive deterioration in end organ function, intolerance to ACE inhibitors, systolic blood pressure under 90, and inability to walk at least a block, and worsening sodium and frequent ICD shocks. Now, interestingly enough, even though there's ESC criteria for advanced heart failure, in MITRA FR, there was no specific exclusion criteria to actually exclude these patients. So some of the patients who went into MITRA FR could have been these patients because they were not a part of exclusion there. So again, to reiterate, the stage D patients are those who really, are very symptomatic, are hypotensive, needing more diuretics, and if you want to have a hemodynamic definition, they are patients who have a cardiac index under 1.8 and or with less than 2.2 with inotropes, and with having end organ dysfunction or symptomatic hypotension. So our algorithm here, when patients present with heart failure with reduced ejection fraction with severe MR, is to really see if they come into stage D heart failure. If they do, then we make a referral for them to undergo an LVAD or a heart transplant. Now, if they have stage C heart failure, our role is to look at whether they're optimized or not. And I'll go into what I mean by optimization. Now, again, if they're not optimized, then optimize their medical and device therapy. And despite that, if they have severe MR, then we make a referral for valvular intervention, and now it's a possible mitral clip. Now, if a lot of times with medical and device therapy, we are able to optimize so that their mitral regurgitation actually decreases, and we continue medically managing these patients. So when we look at what we mean by optimization, we are all aware of guideline-directed medical therapy, where it includes ACE inhibitors, ARBs, or now ARNI, which is sacubitril along with valsartan for patients with HFrEF, along with beta blockers and mineralocorticoid antagonists. But more importantly, so a lot of them, because they are part of guideline-directed, therapy and part of core measures when people get out of hospital, a lot of them are already on these therapies. But what we don't often, pay attention to is what is the dose of these medications that they are on. And so I wanted to, talk about that in the next few slides. So when you look at mean dose in trials of patients with HFrEF, the average lisinopril dose is 30 to 35 milligrams a day. And an enalapril dose is about, close to 20 milligrams daily. Now, if we look at what was the ACE and ARB use in CoOp or MITRA FR, it's about 65 to 70%. Though I could not find the doses used in these trials, even in supplement information. So that's at least not available. And if you look at the ARB doses in the trials, you're looking at losartan dose of 130, valsartan dose of almost 250. and candesartan 24. This is all almost at, kind of the upper limit there. And when you look at metoprolol succinate dose in MERIT-HF, it was 159, where 200 is usually the maximally accepted dose that we use. And same for Coreg, you're looking at 18.75 BID, and bisoprolol 8.6 milligrams daily. Now, beta blocker use in CoAPT and MITRA-FR was almost close to 90%. Again, the dose is not available, at least publicly. The same with aldosterone antagonists. You're looking at about almost 42.6 milligrams of eplerenone, where 50 milligrams is the highest dose. And the aldosterone antagonist use in both CoAPT and MITRA-FR is actually quite low at 50%. And with hydralazine isoridil, which again is indicated in patients with who are African American and still have room to optimize, the dose is 175 over 90 milligrams daily. So ivabradine is a new medication, which is actually a funny channel blocker, which decreases the heart rate, and the average dose is 6.5 milligrams. And actually, since it's a new medication which just came into market, I didn't find any information about what percentage of these patients who went into MitraClip or MITRA-FR were actually on ivabradine. So, what are the barriers to optimization? So oftentimes, only 50% of our patients reach median trial dose in real-life setting. And some of the reasons we see when we see them for an opinion for advanced cardiac therapies is concomitant, conditions. When patients have COPD, their beta blockers are, either taken away or are left at lower doses, where there is really no data. There are at least 3 studies showing that beta blockers are not contraindicated in them, and they really don't lead to more bronchoconstriction. Though, if really people are so worried, then they can choose bisoprolol, which really has no effect on the beta 1 of the beta 2 in the lungs. And again, hypotension. Oftentimes patients are left on lower doses of Coreg because of hypotension, and we often are able to go up on switch them to metoprolol and are able to achieve much higher doses than what they were on before. And the other thing is to really look at, a lot of people, see the problem with heart failure optimization is a lack of target. Unlike, diabetes, which has hemoglobin A1C, you really don't have a target in heart failure. And if you target to, say, wedge pressure and try to over-diurese them, you will not be able to start, ARBs or ACE inhibitors. So in these patients, oftentimes we, decrease the Lasix dose so that we can go up on their ARBs or ACE inhibitors. And again, with CKD patients, you should expect that there will be at least a 30% increase in creatinine with ACE or ARB, and that should not be a reason to withdraw ACE or ARB, ARBs. So just a brief word on role of dyssynchrony, because once you've optimized medical therapy, then you really need to see if these patients are good candidates for CRT. And this is a really nice study, which is just in print from European Heart Journal, where they looked at actually strain and looked to see what was the effective regurgitant orifice area and regurgitant volume. And as you can see here, as the the QRS widens and as the dyssynchrony, this is actually papillary muscle dyssynchrony that they were able to study using strain imaging, that your EROs and the regurgitant volume was much higher. And when you looked at actually those functional mitral regurgitation patients who responded to CRT, the ones who really responded were the ones with more dyssynchrony or more wider QRS, and they were actually able to bring down the EROA to 0. I mean, it's a little too good to believe, but their regurgitant volume was really reduced as well. So showing the mechanism between why CRT is so effective in these patients in reducing functional MR, and that should be considered in a lot of our patients. Now, at least here, during the last 3 years, I've had 2 patients who undergone this His bundle pacing, which has reduced their MR too. I think that is still so new that we don't have a lot of data, but I think that's something that we'll find out in the future. So just to go over what we found in the CoOp study in our center, we had about 38 patients screened. We thought 3 were stage D and they underwent LVAD or 1 underwent transplant, and 28 were stage C. And out of which we were able to optimize 17 patients with medical or device therapy, and their MR decreased. And out of the 11 whom we, despite optimization, continued to have severe MR, went into the MitraClip trial. Now, there were a few patients who, out of this would be 31. So the other 7 patients, some were deemed to be mixed, so they got a commercial clip or one got surgery. And I think one of them, we also use CMR here to exclude sarcoid or other infiltrative diseases. So I think one of them got excluded due to that. So in conclusion, I think identifying stage D patients will help recognize those patients who will not benefit from a valve intervention. And optimization of stage C patients with medical and device therapy can decrease the degree of mitral regurgitation. And I think recognizing barriers for medical optimization can actually help them optimize further. And to be honest with you, even after valvular intervention, when their blood pressure goes up, I think we should continue optimizing them. And I think recognizing these barriers will help them optimize them further. So thank you very much.
That was great. Thanks, Ash. One question: in CoOp, did they mention the use of, or what's your opinion, the use of Entresto? Because that seems to have.
Right. So at least, personally in my experience, I think that's a really good left atrial drug. It looks like, the left atrium gets smaller even after mitral valve intervention, some of them that I've started Entresto on. Since it was such a new drug, the rate of use was really low. So okay. RNE use in both MitraClip and in MitraFR was only 5%.
Ah, okay. Oh, I'll defer to Ash.
So it is a combination drug which has valsartan, which is an ARB, along with another medication called sacubitril, which is a neprilysin inhibitor. So neprilysin is an enzyme which actually, breaks down bradykinin and a lot of other vasodilators, which, if concomitantly inhibited, increases, and including BNP. So it breaks down BNP as well. So it increases natriuresis, but also there is a lot of anti-fibrotic effect of these vasodilators and anti-proliferative, really paracrine hormones, which are secreted by the left atrium, ANP, BNP, substance, P, and so the hypothesis is that not only does it lead to natriuresis, but also a better left atrial remodeling. So, and when it was compared in Paradigm HF head-to-head with enalapril, it provided about a 2-year survival advantage. So if, when you put patients on ACE inhibitors, if they were to get a survival advantage of about 11.9 years, with an ARB ARNI, they were able to live 13.9 years when patients with. So yes, so valsartan, there were 6 brands of valsartan which were sourced from this particular manufacturer, which was, the lack of a better word, not defective, but there was an additive which was kind of toxic. So those...
It's contaminated.
So those 6 were brands were pulled off. Yeah, but since this Entresto, which is valsartan and sacubitril, is still not generic, so it is manufactured from one facility where the valsartan's the good valsartan. Yeah.
Great, thanks, Ash.
Okay, thank you.